Hello, I'm Dr. Noel Wagner, Saginaw-Tuscola Medical Control Authority, here today to talk about lights and sirens, everybody's favorite topic. Uh, Comes as no surprise to you that we've been discussing decreasing our use of lights and sirens. It's a national trend, it's a statewide trend, it's also an MCA trend. Um, we're going to use less of them. Our understanding of lights and sirens in 2024 is very different than it has been over the past 30, 40 years in EMS, and we're realizing that it just doesn't add that much to certain situations, and those are the ones that we're going to try to decrease. Now, when you're looking at lights and sirens usage, there's two distinct areas for EMS. There's going to the patient, and there's going to the hospital. We're going to discuss the going to the patient on a separate video. We still have some work underway on that. We're going to fine tune our protocols. We're going to address a lot of that with determinants on the dispatching end. So more to come on that. But today we're going to talk about taking your patient to the hospital. This is something that's very easy to address right now. We can do it. You can start doing it right now if you haven't done it already. So um, the key thing to keep in mind is when we're going to a patient, it's usually because we need to breathe for you, push on your chest, or defibrillate you. And there may be some areas around that that lead to us needing to go lights and sirens to save a minute or two, being generous. When we already have the patient and we're going to the hospital, that doesn't apply. I'm sitting right next to you. So it's very easy for me to breathe for you, push on your chest, or defibrillate you if that situation arises. So we really need to try and find out what situations really warrant saving a minute or two going to the hospital. And there's a few, but there's not very many. Um, Critical trauma. Critical trauma, the hospital has something that they need. They need blood, they need an OR, they need a surgeon, they need a tube. They need something that doesn't exist in the setting. And in that case, a few minutes may make a difference. So critical trauma, yes, lights and sirens to the hospital does make sense. An impending arrest. Any arrest that you can prevent is better than an arrest that you try to work. So if you have somebody that's truly critical for whatever reason, yeah, that makes sense. Then you would light it up, and that's worthwhile. Um, the one that always comes up is airway. Everybody's always worried about the bad airway. And the reality is when we look back at EMS again over the last 30 or 40 years, a lot of these bad airways were really just people we couldn't force an intubation on. The airway really wasn't that bad. We just couldn't get them intubated, but we could still oxygenate them, could still get enough ventilation. So that one it comes with a little bit of caution. You know, just because you can't get a intubation blade pried between somebody's teeth doesn't mean that that's a bad airway. So again, you have to use some judgment on that, but it's not an automatic default to that. There's two other ones that come up pretty often that we might be a little bit too eager to light it up for, and that's strokes and STEMIs. All right, let's look at what we're dealing with these. Stroke. You have a 3-hour window to give thrombolytics. Does it make logical sense to light it up to save a minute or two with a 3-hour window condition? No, it doesn't. It can't be justified, especially after you've sat on scene for 15 minutes or more, when you could very easily have put the patient in the ambulance, started rolling, got your blood sugar before you get to the hospital, given early notification. Much better plan of action for stroke. Now, you know, that's the typical stroke. I'm weak on this side. I can't move this side. You know, if you have somebody who's unconscious with a blood pressure of 300 over 200, different scenario. Those are not very common. They're few and far between. So you can't just automatically say it's a stroke, we're going to light it up. Doesn't fly. Minute or two in a 3-hour window is not justifiable with what we're doing. And the other is a STEMI. Um, Again, just like a stroke, it's a serious condition, but to light it up, get there 1 to 2 minutes faster so they can sit in the ER 1 to 2 minutes longer because we didn't notify the cath lab team early enough does not make any logical sense. Also, if we're close enough to the hospital where the cath lab hasn't had time to get in, whatever reason, it's just not justifiable the vast majority of the time. There was some research tangents going off a few years ago trying to figure out if the increased adrenaline could make STEMIs worse by going licensed sirens to the hospital, again, just to save a minuscule amount of time. And I'm not too sure where any of those went. They were kind of interesting, but there is a thought process out there, that we need to be cautious. But again, just because it's a stroke or a STEMI doesn't mean you turn on the lights and sirens. What it means is that you get them in the ambulance and you start driving instead of sitting on scene, doing a lot of things that can either be done en route to the hospital or don't need to be done at all before you get to the hospital. Okay? Keep that in mind. If you pull up your protocol, the lights and sirens utilization protocol, it's 8.2. If you're following along on the MCA website, there's a couple things in there to keep in mind. One is Section D. Section D is really a nice addition that the state decided to put in there, and we appreciate it and we approve of it, is that you can turn your lights and sirens off and on as needed. So you have a priority one patient, you're taking him to the hospital, you're driving normal traffic, and then you come into some obstruction, some traffic, some road condition, something that, that 1 to 2 minutes is now turning into 5 to 10 to 20 minutes. You can turn your lights and sirens on, clear the condition, and then whenever it's safe to do so, you can go back to regular traffic. Perfectly okay. Now, we all know that when we don't have our lights and sirens on, we're just a regular vehicle. Hopefully everybody gets that common sense point right there, because the purpose of not having them on is to drive like a regular vehicle. Okay. So look at Section D. It fully authorizes you to turn them off and on as needed, in certain scenarios, if you've initially started without the lights and sirens. So it's not an all or none phenomenon. Okay, keep that in mind. Use them sporadically if needed. Okay, and there's another section in here, and I kind of like this one. Section H, if you turn the next page on it, it says, if you're in doubt, contact medical control. We'll be glad to help you make a lights and sirens decision if you need to. But just realize we're trying to go to less. In the MCA right now, responding to calls is about, this 2 calls, is about 61 to 67%, depending on which year's data you look at. We're going to bump that back. The last data we have for going to the hospital was 2% lights and sirens to the hospital. We should probably be at least half that, down to 1%. That's very easily doable. I foresee us at some point in the future starting to review run sheets with lights and sirens transports to the hospital, just to see where we're at with this, to make sure we're being appropriate. But again, one of the key concepts is that getting to a patient is a different mindset than getting the patient to the hospital, and how we're going to do that. Okay. So again, any questions, let me know. Feel free to let Rob or Audrey in the office know also. We'll be glad to talk about this with you or explain it. But it's going to be an improvement in driver safety without a degradation in patient care. And for that, again, Dr. Noel Wagner, STMCA. Thank you.